So hi, everybody. Welcome. I'm Dr. Sydney Ortiz, and on behalf of Mount Sinai, I'm excited to introduce Just Talks, an equity and social justice lecture series brought to you by the Department of Psychiatry's Change Committee. This lecture series is coordinated by the Community Engagement Subcommittee, and this year's theme focuses on the relationship between psychiatry, mental health, and social determinants of health. And with that, I'm excited to introduce Dr. Caitlin Pinciotti and her talk, Justice-Based Exposure and Response Prevention for Identity-Related OCD. Dr. Pinciotti is an assistant professor in the Menninger Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine. She's a clinical psychologist and researcher specializing in the study and treatment of obsessive compulsive disorder, trauma, and post-traumatic stress disorder. She obtained her PhD in clinical psychology at Northern Illinois University and specializes in pre- and postdoctoral training in obsessive compulsive and related disorders. She's a recipient of the 2024 Bicentennial Lectureship Award by the Hartford Hospital Institute of Living, honoring her innovation, advocacy, and patient-centered mental health care efforts on justice-based exposure therapy for obsessive compulsive disorder. Thank you for joining us. We're so excited to have you, Dr. Pinciotti. Dr. D'Amberville will now share how to collect your continuing education credit.
Hi, everyone. I'm Dr. Naomi Demerville. Thank you again for joining today's Just Talks conversation. So continuing education credits for today's talk are available to psychologists who've registered for CE and for free for Mount Sinai affiliated physicians, nurses, psychologists, and social workers only. Throughout the talk, we'll be putting information on how to collect those CEs and CMEs in the chat. If for some reason you did not register via Eventbrite with your Mount Sinai or HHC email and would like to make sure that you obtain CE credit for your attendance, please use the chat to DM myself or Dr. Stahl, your full name, your credentials, and your Mount Sinai email. Lastly, if you're joining as part of a unit or a group, please note each attendee's name and credentials in the chat. If you have any questions or concerns about CEs or CMEs, just place them in the chat and we'll get back to you. And enjoy the talk. We encourage comments, reflections, and questions for Dr. Pinciotti in the chat box and questions in the Q&A box. All questions will be answered at the end of the talk. Thank you.
Well, thank you both for inviting me to join you today. I'm really honored to be here and excited to talk about this topic and look forward to whatever questions or reflections folks have at the end. Let me go ahead and share my slides here. So I'm going to be talking about justice-based exposure and response prevention for identity-related OCD. And I know that we have probably a range of familiarity in the audience in terms of what OCD is, what it looks like, and what ERP is. So I'm going to briefly touch on those things. So OCD is characterized by intolerance of uncertainty and core fears that typically underlie surface level content themes. So there's sort of the surface level theme that presents, but there's something kind of underlying that's really driving the obsession. And there truly is a virtually limitless range of themes OCD can really latch on to anything. And there's one sort of branch of themes that are sometimes called taboo, unacceptable, repugnant thoughts that we know that up to about 43% of people with OCD will have these. Subsumed within this are fears that can center on identities or characteristics that are marginalized in some way. And this is where that term identity-related OCD comes from. So identity-related OCD can involve a fear of being, becoming, being perceived as, being unsure about, or being punished for being some sort of identity or characteristic. These fears or doubts are linked to stereotypes about certain identities or characteristics, concern for mistreatment should one have an identity or characteristic, and catastrophic beliefs about the causes or consequences of holding a particular identity. And so the important piece here is that these identity-related themes are really predicated on society deeming certain identities unwanted or undesirable in the first place. So we know that obsessions latch on to something that, according to the DSM, in most cases would make someone feel anxious. Now, sometimes these are internalized beliefs. So someone who, let's say, has obsessions about their sexual orientation may not feel like they are kind of overtly homophobic or biphobic, but they still recognize that holding that undesirable identity in a hostile society would carry some sort of consequence and is therefore distressing. I have this picture of various eye colors to illustrate that, one example that I give is that, again, with OCD, anything is possible. So I'll sort of have that caveat. However, it would be quite rare for someone to have their OCD kind of latch onto an obsession about their eye color. So I have green eyes. The likelihood that tomorrow I would obsess about, oh my gosh, well, what if I actually have brown eyes, is probably pretty low because there isn't any sort of societal consequence of one eye color over the other. Another example to think about would be, there are some cultures, some indigenous cultures or Eastern cultures that really revere gender diversity. In some cases, even feel that people who are gender diverse, possess kind of magical or spiritual powers and have a lot of, honor and regard for those folks. We would probably not see in societies like that very many people who obsess about their gender identity, because again, there isn't some sort of negative consequence associated with that. So the key point here is that these symptoms really are culturally bound. It doesn't necessarily mean that this particular person is homophobic, transphobic, ableist, whatever the case may be. But we live in a society where those messages are being communicated to us, and there can be an awareness, even if it conflicts with someone's values, that there would be consequences to holding certain identities. Now, this list is not meant to be an exhaustive list of different manifestations of identity-related OCD, but just to give you a sense for the different ways that OCD can kind of latch on to identities or marginalized groups. Thinking about race and ethnicity, this oftentimes manifests as a fear of being or being perceived as racist, or engaging in some sort of racist behavior on impulse, often in the form of a fear of, I'm going to accidentally just sort of blurt a racial slur in front of someone. I will say there's a caveat to including race and ethnicity here, because I have some research that will be coming out soon that actually shows that fears of being racist don't really cluster together with these other identity themes. They sort of cluster together with other themes related to moral, moral wrongdoings. But for the purpose of just thinking about how this can apply more broadly, I've decided to keep this on the slide. In terms of aging, this can be a fear of being contaminated by older adults or some sort of, stereotyped unwanted characteristic. I worked with a patient, for example, once who, although he himself was also older, he feared that being around other older adults, he would sort of catch, this sort of stereotype of being kind of cranky and difficult from fellow older adults. It can also involve a fear of developing certain mental or physical changes that are associated with aging, such as dementia. Disability and diagnostic status, again, can have that kind of contamination overlay, a fear of being contaminated by someone who has a feared disease or disorder, a fear of having or developing a certain disease or disorder. Oftentimes folks will say a fear of going crazy, which I have in quotes, because really what they mean is, having a psychotic episode. Related to socioeconomic status, this can manifest as being contaminated by unhoused or homeless people, or a fear of oneself becoming poor, unhoused, or financially unstable. And then gender identity and expression and sexual orientation sort of look the same, but latch onto those different key aspects of identity. A fear of becoming, or being perceived as a different gender or sexual orientation, or simply a fear of just not knowing. And so just to quickly level set about what exposure and response prevention for OCD looks like. So sort of the basis for ERP is that people develop these pathological if-then beliefs. If I do this, then this bad thing will happen. If I don't do this, so if I don't do this compulsion, then this bad outcome will happen. And the more and more people avoid feared situations, and avoidance can also be engaging in these compulsions or these safety behaviors, the more anxiety and fear really grows and maintains, and more things feel sort of out of reach for that person. Their life really constricts. So the way we implement ERP is working with the patient to identify these feared and avoided situations, as well as the behaviors that they engage in when they're feeling anxious, and develop an individualized exposure hierarchy that they then sort of repeatedly approach these different feared and avoided situations, while importantly resisting compulsions. That's the response prevention, the RP of the ERP, which is really crucial. And so it's believed that there are sort of three main tenets of ERP. There's anxiety habituation, meaning that as you repeatedly confront something that makes is that your anxiety will start over time. I have a bit of an asterisk here because there are some folks in the field who are kind of moving away from the habituation model and towards the second bullet point here, which is inhibitory learning, or having a corrective experience. In other words, you typically wouldn't do because you have this sort of catastrophic if-then belief, and really challenging that almost like an experiment and learning that either the feared outcome didn't happen, or if it did, perhaps it wasn't as stressful as one thought it would be, that they actually really had the tools to navigate that. Because of point three, which is that people really develop self-efficacy, this belief in their ability to handle things. Now, what's important when I talk about justice-based ERP is this isn't a critique on ERP broadly, but rather an observation that our approach to ERP has become a bit misaligned from its original intention. So something that I hear often from folks in the OCD field is the content of obsessions is irrelevant. You just use ERP, whatever they're afraid of, have them do exposures to that thing. Don't get caught in the weeds, because then you'll just be ritualizing with them. Now, while I agree that we don't want to ritualize with patients and sort of get into the nitty-gritty of perhaps why they have a particular obsession or what it might mean about them, I don't think it's totally accurate to say the content is irrelevant. What happens when you have this sort of blanket assumption that ERP is ERP and you just sort of apply it universally is that you start to target obsessions or compulsions, regardless of how inaccurate or distorted those underlying beliefs might be. There can become this kind of overemphasis on those surface level fears, and not as much of an emphasis on the core fears and intolerance of uncertainty that underlies those fears. So these can come in the form of overcorrection exposures, where someone might ask their patient to do something that seems a little bit extreme, with the idea that if you can handle this exposure, within the context of treatment, then when you're out in the real world and something much less extreme presents to you, that you would definitely be able to navigate that. You would have built that self-efficacy. But the issue with using overcorrection exposures, particularly with identity themes, is that, for one thing, surface level fears can change. So many people with OCD will say, I've had OCD for decades. When I first started having symptoms when I was a kid, I maybe started with religious obsessions and then turned into checking, and now it's this and now it's that. It sort of bounces around. And I would argue that in these cases, perhaps what's happening is that underlying core fear is not addressed. That core fear still exists. It's just now manifesting in a different surface level theme. So we can sort of refer to these overcorrection approaches as almost like a fear factor approach. If you all remember that, if you were old enough to remember, perhaps I'm dating myself, that reality show that essentially had people do these really, really extreme things like immersing themselves in a pit of snakes. And these are really that kind of high shock value exercise, but with low association with someone's actual values or what they need to be able to do to function well. And so there's this sort of prioritization of like, how much anxiety can we squeeze out of this exposure without really considering, does this person actually need to be doing this behavior to live the life that they want to be living? And as this relates to identity themes, we can inadvertently reinforce stereotypes, and we can burden provider or others who may be, in proximity or somehow related to the exposure. So the key here, the takeaway, is that culturally bound symptoms deserve culturally thoughtful treatments. And just to sort of perhaps make this a little bit more concrete, I wanted to share some experiences. The first quote will be from an ERP provider, and the second quote will be from someone with OCD. And you can follow along while I read aloud. I remember sitting with a patient who was dry heaving, watching a YouTube video of two men kissing as their exposure. During that season of my life, I was coming out to my family, and I watched my patient play out my fears that people did in fact see me as undesirable, nauseating, and tolerable at best. In focusing on tolerance as the goal of sexual orientation OCD exposures, I failed to educate, intervene, or narrate to myself how dehumanizing the work felt. It was not until stepping out of the role that I started to feel the aftershocks and regret about my work with SO-OCD patients. I passively assumed that my discomfort was the hard-earned process of habituation. Sitting in that tension led me to see that a justice-oriented lens was missing from the treatment process. SO-OCD exists in response to heteronormativity, the profound societal preference towards straightness. Although ERP provided measurable improvement in SIBOC scores for my patients, this is the Child Yale-Brown Obsessive Compulsive Scale, it did not address the root cause of why the patient's SO-OCD was so distressing in the first place. Set apart from other diagnoses, SO-OCD is a behavioral health manifestation of homophobia that demands historical context, recognition of trauma, and individualized treatment planning in order to adequately treat the disease instead of its symptoms. In doing so, clinical progress does not have to come at a cost to LGBTQIA+ people who are already on the fringes of society. And this is from a person with OCD. I ruminated many hours each day trying to make sense of the injustices of global capitalism. I avoided leaving the house in workplaces, such as retail stores, where I perceived people's labor was often exploited without much agency or choice. My therapist told me to go to the local mall and to look at mall staff, while internally saying to myself, I'm so glad I'm privileged and don't have to do a miserable job like them. It felt really icky and did not help me develop a more useful conceptualization of my experiences of socioeconomic privilege. Instead, it only reinforced the individualistic hierarchical logic of capitalism that contributed to the obsession in the first place, focusing on my individual guilt rather than systemic context. Now, this is a fictional exposure hierarchy, but it's drawn from examples that I've observed clinically, that I've read in written works, that would perhaps be given to someone who has sexual orientation or gender-themed OCD. These would be examples of overcorrection exposures, things like shaking a hand with an LGBT person and resisting hand wash, that sort of old belief that you can sort of catch the gay. Find someone who meets sort of your stereotype of what LGBT people look like and go and talk to them or flirt with them. Dress overly feminine or masculine in public in this really, again, stereotyped way. Use a slur. Talk to a stranger and I have this in quotes, in a gay way. Sadly, these are actual examples that I've pulled. Describe really graphic homosexual sexual acts to someone of the same gender. Write a worry script about how horrible it would be if it turned out that you were LGBT. Practice coming out to someone who responds really negatively to you. Or in the example that I just shared, watch a video of two men kissing and sort of tolerate that disgust that's arising within you. Now, hopefully those already sort of gave you that kind of icky feeling in the pit of your stomach, like that doesn't feel good. That doesn't seem like the kind of treatment that people deserve to be engaged in. But just in case I haven't quite made a point, let's take a couple other common presentations of OCD. So some folks will have pedophilia OCD, where they obsess about the possibility of sexually abusing children. Now, the importance here with OCD is these fears are ego dystonic, meaning that they're not They're not at all related to the person's actual values or who they are as a person. In fact, these are folks we would say would be the least likely to act on these thoughts because they're so aversive and so unwanted. In this case, we wouldn't say to someone, all right, your exposure exercise is to abuse a child and see how you feel. See if it's true that you actually are a pedophile. Similarly, people may have obsessions about harm. They may have kind of intrusive images that they're gonna sort of lose control and grab the nearest knife and stab someone. We certainly in these cases wouldn't say, okay, well, go ahead, grab the knife, stab someone, stab a loved one, see how that feels. Nor would we ignore the context of, say, their spouse has a trauma history, maybe even their spouse has been held at knife point. Okay, no matter, this treatment is important for you, so you're going to do exposures where you practice holding a knife up to your spouse and just sit with that uncertainty. We would never do these things, right? And I think the key point here is that doing the thing that you're afraid of isn't always the goal in exposure therapy. It is if it's something that brings you closer to your values and things that you need to be able to do to function. But these examples, I think, are pretty clearly, those are not things that people need to be able to do. And these can be really harmful for the people impacted by them. And so quality ERP really has to consider the context in which these exposures are being assigned, consider who may be impacted by them, both people sort of in immediate proximity, as well as just sort of our broader responsibility to society, and really considering our ethical responsibilities. I won't sort of belabor the point by going through all of these, but I did go through the APA Code of Conduct and sort of pull out some of the ethics that are related here in terms of, how it's incumbent on us as mental health providers to really be safeguards for all of society and not just the person sitting in front of us. And so this work led to the first publication. Now there have been a few more that have come out since then of this call to action paper that we published in Behavior Therapy, where we sort of offered this critique of using overcorrection exposures for sexual orientation and gender themed OCD, and offered recommendations for how to take a more justice-based approach to these themes. And so let's get into that. How do we conduct evidence-based ERP through a justice-based lens? So first and foremost, we defined justice-based treatment as an equitable, thorough, and compassionate lens through which to conceptualize and implement mental health treatment so that all impacted persons, client, provider, and society are respected. These are the fundamentals of justice-based ERP. So first and foremost, at a basic level, considering the language that we're using. When this theme first sort of emerged and was recognized, it was referred to as homosexual OCD. Now, this word, for one thing, is now considered a pejorative word by most people, but it also doesn't fully capture the range of sexual orientation themes within OCD. So although it's true that a straight person could obsess about being gay, there are also folks who may be gay, lesbian, bi, who may obsess about being straight. And so we now use the term sexual orientation OCD to be both more inclusive and more accurate. Another point here, as I mentioned at the beginning, that this sort of overarching theme, repugnant, unacceptable, taboo thoughts, right now, these themes, because there hasn't been that much research on them, are just sort of subsumed under them because there's nowhere else really for them to go. But we need to think about the messaging that we're sending folks who are trans or sexual minorities, that we consider, obsessions about sexual orientation or gender identity to be repugnant or unacceptable in some way. In terms of conceptualization, it can be really helpful to identify the historical or the systemic roots of the obsessional theme. This can provide context for where these themes come from, because again, most of our patients will say, I feel sort of ashamed because this obsession is so counter to what my values are. I don't know where it came from. And so we can help clients externalize those biases onto the society that taught them. And in doing so, help to reduce that shame, just giving an understanding of where this can come from. And then really sort of the meat and potatoes is doing exposures related to uncertainty and core fears, neutral and positive stimuli, and psychoeducation, which we're going to get into. But first, I want to circle back to that individual with OCD lived experience who shared about what her therapist was having her do and how it was unhelpful. She goes on to say, what actually helped reduce my OCD symptoms was learning about interconnected systems of oppression, including colonialism, capitalism, and white supremacy, which allowed me to begin developing a more contextualized, systemic understanding of my privileged identities. This understanding opened up possibilities for me to instead relate to the injustices my OCD had previously latched onto in actionable, non-OCD ways, such as getting involved in collective action. Now, certainly these topics are not going to be relevant for every single person who has identity-related OCD, but in this case, this person was really grappling with her privilege, and her OCD was really latching onto that, and it was not aligned with her values to lean into that and sort of spit on people that her OCD deemed beneath her. It was much more helpful for her to figure out a way to still engage with her values in a non-compulsive way. Uncertainty and core fear exposures function to help us target the root of the problem. So we can use kind of that downward arrow approach to identify what the core fears are and do exposures to those. So for example, someone who obsesses about being gay, that's the surface level fear, but there's a core fear underlying that. It could be, well, if it turns out that I'm gay, then it means that I'm a fraud. I've been living this inauthentic life. I've been lying to myself and to others. And we can do exposures to that, both specifically related to being gay, but also broadly related to other situations where the person maybe was inauthentic or not completely honest. And then doing exposures that help people tolerate uncertainty. So if the core fear is being authentic, I imagine that doing exposures in which the client discusses other times where they were dishonest, that would also be quite triggering for them and be, good stimulus for exposure therapy. Perhaps the core fear is being stigmatized or mistreated by other people. Maybe we can do exposures related to other times in which the client felt like they were ostracized. My guess is that there's probably still a memory of a time on the playground where they were bullied or not allowed to, play with their other friends, and that has really stuck with them if this is a core fear that they have. Related to intolerance of uncertainty, this can look like, future events and what those look like if you never gain certainty about your identity, or maybe there's a lack of some of these events. Maybe you never marry because you can't quite figure out what your gender identity is. You can also sort of lean into the fluidity and arbitrariness of labels, if that makes sense for that person. Neutral and positive exposures allow us to engage with that surface level content, but without harming the particular community. So some examples as it relates to sexual orientation, gender identity would be engaging with neutral stimuli like pride flags, doing something neutral like just simply writing a coming out letter without having someone respond really negatively to it. Or talk to someone of the same gender and tolerate the uncertainty that that person may be attracted to you or that they may think you're attracted to them. Not only is this something that's more accurate and justice-based, but I argue is a much more potent exposure because OCD really thrives on creating these like neat and tidy boxes that we can put fears in because it makes it easier to avoid them. But if we educate folks on you really can't tell what someone's sexual orientation or gender identity is just by looking at them, then now all of a sudden everyone becomes a potential stimulus for exposure therapy instead of people who just simply meet certain stereotypes. Some positive examples, and I have if appropriate, so if this wouldn't provide compulsive reassurance, engaging in behaviors that promote positive attitudes about the LGBT community, maybe an imaginal script where the client learns that they are LGBT and they actually end up living a happier life. Maybe they leave their current partner, which would still be quite anxiety provoking for someone who really cares about their partner and their current lifestyle. And then lastly, psychoeducation exposures really function to sort of twofold, give us stimulus for an exposure while also providing corrective information. This would be, if this is relevant for people, psychoeducation about any number of things. Again, as it relates to SO and gender identity, this could be, how identity develops or maybe fluid over the course of the lifespan, how we can sort of differentiate different aspects of identity. There's gender identity and gender expression. There's sexual attraction, romantic attraction, so on and so forth. The historical context of different groups of people, and if relevant, you could process themes specific to the client. So, how would we sort of map both your masculinity and your femininity, for example, if their OCD really wanted them to be all cisgender or all transgender. So some points for reflection, and these examples are all centered on SO and gender-themed OCD, but you can sort of take these out and sort of replace them with these other themes, and this would all still be relevant. Does this exposure tokenize or out LGBT people? Does it reinforce stereotypes or add minority stress to the people impacted by them? Does it ignore historical trauma for LGBT people? Could you make this exposure a different way and achieve the same result? Can it be made about appreciating or celebrating a community rather than simply tolerating it? Would this exposure need to be clarified to peers or others who were in proximity or heard you discussing it? Is the patient's distress rooted in cis or heterosexism? And then this last one, which I have bolded because I think that really a lot of this sort of boils down to, would you feel comfortable doing this exposure in front of an LGBT person? As an example related to racism OCD. After doing some of these trainings, I had someone reach out to me who worked in a partial hospitalization program, so sort of a milieu-based program, who she herself was a provider who was Black. And there was a patient who had obsessive concerns about being racist, blurting racial slurs. And so this patient was put in the treatment room with whiteboards and told to write the N-word on the board. And the staff simply told this Black provider, okay, between 11 and 11:30, just don't go into that room. Just avoid that room. While I appreciate that there was even that level of thoughtfulness of protecting that Black provider from having to be exposed to that word, perhaps without context, I think that that's instead a moment where there could have been some reflection. If we feel like we have to protect people from the treatment that we're doing, then I think we need to really sort of check in with our gut and reevaluate the treatment that we're providing. And so a justice-based hierarchy for SO or gender-themed OCD can include things like, again, holding a pride flag, tolerating uncertainty that a stranger you're engaging with may be LGBT, attend an LGBT event where allies are welcome, psychoeducation exposures, watching content created by those creators that are less likely to sort of play up stereotypes like hypersexuality. Describe the harmful impact of slurs to someone else, compliment someone, educate someone, come out to someone who responds neutrally or positively, and then writing a worry script about leaving your current partner for an LGBT person. As you can see from these examples, these would still be anxiety provoking. They would still target the fears and the avoidance that folks are coming into treatment with, but in a way that's much more respectful towards the LGBT community. It doesn't have to be one or the other. So now I want to share some recent research findings with you. I'm really excited about this. The first couple of publications that I put out on justice-based ERP were more kind of theoretical in nature. But this is findings from the first empirical study showing that people who have these themes really prefer a justice-based approach over an overcorrection approach. And so this data is a sort of subset of data from a larger study called the National OCD Survey that I've been collecting since August of 2023. It's actually going to be wrapping up soon. The larger study is focused on looking at regional differences in different OCD presentations. So things like do religious obsessions, are they more prevalent in, more kind of religious conservative states? Are obsessions about racism more prevalent in, more urban areas, so on and so forth? And so this was a subset of adults with OCD across the United States who participated in this survey and who indicated that they either currently or previously have had some sort of identity related OCD theme. And so what we did with these folks is, after getting some information about their OCD, we then presented them with 2 different exposure hierarchies. They only read one at a time. One of them was an overcorrection hierarchy, and the other one was a justice-based hierarchy. What they would do is they would read one of the hierarchies first, answer a series of questions, and then they'd read the other hierarchy and answer those same questions, each about the hierarchy they had just read. We counterbalance these so that half the people got overcorrection first, then justice-based, and the other half got justice-based first and then overcorrection, in order to try to reduce bias, or sort of priming people into, what we were doing. And these hierarchies were specific to the identity theme that they endorsed. So this is an example of the hierarchies we use for racism, OCD. You can recognize these examples from what we've been talking about. The overcorrection includes things like actually using the racial slurs, or sort of forcing someone who's a person of color to hear you talk about racism. Whereas the justice-based approach is, perhaps hearing a song that used the racial slur, but not singing it. Instead, talking to someone else about systemic racism and tolerating the uncertainty that you could have potentially said something racist or offensive in some way. Here's a different example. This was for folks who indicated disability or diagnostic status obsessions. Again, overcorrection involving this sort of catastrophic, like, watch a video of someone having a psychotic break, use an ableist slur, act like you have a disability in public, versus justice-based exposures, which would be watching videos where people are empowered, where they're living valued lives, describing the harmful impact of slurs, looking at art or media created by people with disabilities. And then ask them a series of questions where they rated 0 to 4. For one thing, first, have you ever attempted to do any of the exposures in the list? And then their perspectives on them, rated from not at all to extremely. How relevant are the exposures in this hierarchy for your OCD fears? How anxious do you think it would make you to do them? If you did them over and over again, how effective do you think they would be in reducing your OCD symptoms, helping you learn how to tolerate uncertainty, and helping you live the life you want to live? Would you be willing to do those exposures with a therapist or in front of a person with that target identity? And then how derogatory or offensive did you find those exposures? And again, these are rated from 0 to 4. The blue bars here indicate the average scores that people reported for the justice-based hierarchy, and the red bars are the average scores reported for the overcorrection hierarchy. And I'll just draw your attention first to items 6, 7, 8. These are your willingness to complete them and how derogatory or offensive you found them. These here were the largest discrepancies we found, where people were reported that they were much more willing to try justice-based exposures, and found the overcorrection exposures to be much more derogatory or offensive. The only thing really that the overcorrection exposures had going for them, if you could even call it that, is that when we asked people, how high do you think your anxiety would be if you tried them? Well, they felt the overcorrection exposures would make them much more anxious than the justice-based exposures. And so overall, we found that people really had a strong preference for justice-based ERP. The largest effects were those willingness to complete or perception of offensive,ness. And we found small to moderate effects related to sort of their treatment outcomes expectancies, how they felt that those exposures would improve their lives. This makes sense because we had about 49% of our sample who had ever tried ERP. So we had a lot of folks who had never tried ERP, and it's sort of a lot to ask people to think ahead of how do you think this would impact your OCD. But even still, we found significant differences. And so the overcorrection exposures ended up being associated with higher peak anxiety expectancy. They expected their anxiety would be much higher, but with less relevance, anticipated effectiveness, willingness, or values alignment. Again, kind of this fear factor approach. And really, these individuals with identity-related OCD just felt that the fear factor approach was not the best approach for their identity themes, and they really preferred a more nuanced and thoughtful approach that was better aligned with their functionality and values. And so the take-home of that study is that was the first research support for justice-based ERP, which is really exciting. It suggests that using a justice-based approach could lead to greater buy-in treatment adherence, and potentially faster symptom reduction if people are more willing to do the things that we're asking them to do, and they're more bought into the motivation for it, instead of like, you want me to do what? Like, it sounds like you just want me to be really mean to these people, and that doesn't feel good to me. And I think really it's sort of an indication that as a field, we're kind of shifting away from that habituation, fear activation model of like squeeze as much anxiety as you can out of every exposure, and more towards what are the exposures we can do that are better aligned with what this person wants to be able to do, with what's important to them, not just let's have them do this thing simply because we know it's going to make them feel anxious. And so some final thoughts. First and foremost, that justice-based ERP is ERP. I always want to emphasize this, that this is by no means a suggestion that we should throw ERP out and do something entirely different. This is merely just a lens to apply to ERP. It does not stray from the central tenets of what we think makes ERP so effective, and in fact, really emphasizes those core strategies, emphasizes that need to get down to the root of what that core fear is and the intolerance of uncertainty, and really address those things. Justice-based ERP seems to be better aligned with our patients' values and needs, as well as our ethical principles. And it could improve buy-in. This is really important because, although we didn't get into a lot of this, there are a lot of stereotypes in popular media about exposure therapy that do make people less likely to want to seek out exposure therapists, despite exposure therapy having so much evidence for its effectiveness. People see sort of these distortions of exposure therapy that use overcorrection approaches, and they think like, oh, I don't want to do that. I'm too scared, or that doesn't make sense for me. And so maybe, just maybe, if we continue to engage in exposure or justice-based exposure therapy, that we can start to sort of counteract that and have people buy in and be more likely to want to try exposure therapy because it's more aligned with their needs. This is just my contact information or ways to follow along with the work that I do. My email address. I'm still on Twitter, but I'm also on Blue Sky, where I try to share out my research there. If you're a nerd like me and you're on ResearchGate, my research is on there as well. And I also have a website where I have some free resources and handouts and worksheets and things of that nature. But with that, I wanted to make sure that we had enough time for questions at the end. So I'm going to go ahead and stop sharing and see if I can answer anything for you all.
Thank you so much, Dr. Pinciotti. That was a wonderful talk. Thank you for kind of highlighting how ERP and the gold standard treatment can be both effective but also ineffective for some, if not really adequately viewed from a more systemic lens. And I'm really mindful of the ways that throughout history, right, sort of the dominant but also shifting cultural narratives around sexuality and just how we view ourselves can pathologize normal variations, right, in identity and sexuality and relationships, and that for those people who are marginalized, that this can further marginalize them in trying to access equitable mental health care. So we do have some questions. The first is, I will just read it. So comments are: the intrusions, obsessions are inherently ego dystonic. People with sexual orientation OCD will all tell you there's nothing wrong with being gay, which is why the disgust is so distressing for them. I see the exposures that you labeled as problematic in sexual orientation OCD as a way to overcorrect and develop tolerance for the disgust. Both patient and doctor are aligned in being LGBT affirmative. Isn't that why we are enlisting those exposures? Because we have both agreed that we are correcting for society's homophobia. And the question is in the Q&A box if you need to look at it a bit further.
Yeah, let me just read that again. Okay. I think that's a fair point. And certainly we, part of justice-based ERP is considering the context that we're doing things, and the context is also that unfortunately we live in a society with systemic homophobia. I think where I would perhaps disagree with this comment is that I don't think the solution is to then lean into the homophobia and have people engage with it or sort of practice tolerating it. I will say also that although it's true that many folks with SOOCD, for example, will say there's nothing wrong with being gay. Not all of them will say that. I didn't cover that in the slides, just sort of for brevity, but especially sometimes when you see the sort of religious intersection with SOOCD, there are some folks who do believe that being gay would be, a sin or bad in some way, and that's sort of a entirely different thing. But I think what you're saying is an interesting point. I just would argue that being affirmative means also engaging in that way with our treatments.
There's a comment in response. Someone said, agreed. I have a teen where sexual orientation OCD is not completely ego dystonic.
Right.
So yeah, I guess can you speak to a little bit more about the ego dystonic versus not, and how a provider can really either frame the exposures or the language or assess that a little bit more?
Yeah, that is a more complicated discussion because then you're sort of moving into the realm of trying to change someone's values, which is, of course, what we're trying not to do. I think one approach, and I have a handout on my website that sort of does this in a systematic way, is to, work with the person. Let's just say that this is a sort of religious or like scrupulosity intersection. Work with this person about what their faith community truly believes. First of all, there could be a distortion there where their OCD might have sort of taken something more to the extreme. So getting a good sense of like, where are they actually related to their peers in terms of their belief system? But then assume that their faith community does have, anti-LGBT beliefs and values. Then, the next conversation could be, what are your values? And, is it possible that your values in some cases could diverge some with the teachings of your faith? This idea that if you believe that God or a higher power has given us all free will, that we all then also have free will to sort of decide which pieces of our religion or our faith fit with our values and which do not. So there could be some people who maybe, want to sort of move past some homophobic or transphobic values, but they feel like they have to hold those because it's so prevalent in their faith community. And there could be a way to have a more balanced conversation, because OCD, again, just wants to go to the extremes. It wants to have these neat and tidy rules and boxes, and we can help people sort of become more flexible. I think, though, in cases where the person truly does have, these beliefs and doesn't want to move on them, then I think it becomes a matter of, I think, first and foremost, your identity as a provider and how you see your work. There's a lot of debate right now, for example, about like, is therapy political? Should we infuse our own values into things? And I think each person has to decide for themselves what makes sense for them as a clinician. But I think where I would go with that is, okay, if this person is coming to me with OCD that they want to work through, it's probably not worth my time to go down a rabbit hole of trying to change their hearts and minds on something. How can I, as a clinician, engage with justice-based exposure without feeling like my goal is to completely change this person's values either, right? Like, this person can believe something. It doesn't mean that I have to engage with exposures that reinforce those beliefs.
Thank you. So some thoughts in response as you were speaking. Someone shared that they've thought about psychoeducation, have thoughts about how psychoeducation about societal internalized homophobia, and appreciate the thoughts about exploring values. Someone else shared that I wanted to comment that I love how this approach really highlights values and feels very consistent with an ACT approach. As someone who blends ERP and ACT in treatment, I can see a lot of clients responding very positively to justice-based ERP. Another question, how do we distinguish between OCD about sexual orientation and actual exploration of sexuality?
That is a great question, and something that comes up often when I do this talk. I always think I wish I could add this slide, but then it's sort of the balance of wanting to have enough time for conversation too. So what I will say is Monica Williams is a researcher who really sort of started the research and the dialogue on SOOCD. She has a lot of early publications, late 2000s, early 2010s on this topic. And she has a chapter from 2008, a book chapter that's titled Homosexual Anxiety. She also has sort of pioneered changing that language, but this is from 2008. And at the time, that was, the language that was being used in the presentation that was more prevalent. All those caveats aside, there's a table in this chapter that does exactly this. It goes through ego-syntonic identity exploration and what that can look like, and then ego-dystonic obsessions, and sort of point by point comparing them in a way that would be much better than I could do even here. So I would recommend utilizing that resource. I send it to people all the time. I think it's excellent. I'm happy to send it to folks if they don't have access to it. But really sort of to briefly answer the question, it comes down to ego-dystonic versus ego-syntonic. Is this aligned with who the person is and what they value? Do they enjoy the thought of same-sex relationships, even if there's also, some anxiety associated? Like, I enjoy this thought, but I'm also anxious about the possibility of being gay, versus are those images so aversive? Do I push them away? Am I able to disengage from them? Is there kind of like a compulsive nature to it? It can be really tricky. And something that I'll say too, that'll sort of like also throw a wrench in this a bit, is that I think there used to be this approach to OCD that was like, if something is true, then it's not OCD. If it's not true, then it is. So as an example, like, if the person is actually gay and they obsess about being gay, well, that's not OCD. If the person, say, is actually a pedophile, then it's not pedophilia OCD. And I just don't see OCD neatly conforming to those rules. I worked with someone once who was actually a stand-up comedian. And, they sort of joked like, yeah, I used to obsess about the possibility that I was gay, and well, turns out I was right. And so, someone could both be a certain thing, and also have obsessions about that. So it's a little bit tricky, but it really comes down to, is it ego-dystonic or ego-syntonic?
Thank you. Is there research about the impacts of doing identity and justice-based ERP for BIPOC therapists, in particular BIPOC populations?
That is a great question. Nothing yet. I have been really interested in doing that type of research. So, now that we have the perspective of people with these themes, let's get the perspectives of the providers who are doing the therapy, and especially those providers who hold those identities. There's no research on that yet. We do touch on that topic of, a Black provider working with racism OCD, or a queer provider working with SOOCD in one of my publications from last year. That's all on identity-related OCD, but there's no data on that just yet.
Okay. And then, sorry, just losing. How can the field support patients in being open to accessing ERP?
Yeah, that's a big one, right? I think that on an individual basis, we can increase openness to ERP by committing to having a justice-based approach. It may just be one person in front of us, but that person can then talk to a friend or a family member who has OCD, who then talks to other people and talks to other people, or maybe they post on a Reddit forum, or go to the International OCD Foundation conference, and we can sort of expand our reach even just through one person. But I think committing to providing treatment in a respectful and sensitive way, the more and more that we do that, and the more of us who do that, the more we really counteract those stereotypes. I think too, it can be helpful to explicitly name them. I like to reference, if we have any Parks and Rec fans in the audience, there's an episode where, oh, I'm blanking on her name, but Leslie Knope's friend sort of engages in this, what she calls exposure therapy with Leslie to prepare her for a date. And it's really quite funny, but not at all what exposure therapy is supposed to be. But you can sort of address, these common misconceptions in the media or ways that it's portrayed, and how we're going to do things differently here. And I think the biggest thing is consent and collaboration. We're going to work together to build this hierarchy. We're going to agree on these exercises. I'm not going to be forcing you to do things. And I really want to know who you are and what's important to you, so that can inform the exposures that we develop together, as opposed to me just having kind of a generic list of, oh, okay, someone with racism, OCD is coming in, let me just give them these exposures.
Yeah. Thank you. We have a few minutes, but we're always interested in hearing how you yourself came to this work, to this field, sort of what about it interests you, and how you feel like it's really allowing you to help the community that you want to serve.
Yeah, thank you. Thank you for that. So I came to this work, specifically justice-based ERP, several years ago. I was working in a large behavioral health hospital setting with a specialization in OCD. And I actually was doing trainings on LGBT issues and OCD treatment. And had done a couple of these trainings throughout the hospital system. And one day there was an RN who attended, who posed a question at the end, something to the effect of, do you think that we should change our approach to doing exposures with SO-OCD? And it sort of caught me off guard, and say more about that. Like, what do you think needs to change? And he proceeded to share his experiences. This is actually the same person whose quote I shared about coming out and watching his patient dry heaving. Started to share his experiences about what it was like to be a queer provider, engaging in these overcorrection exposures with his patients. And I'll admit, because I think it's really important to have humility with this work, that it caught me off guard in a way that I then felt sort of embarrassed that I hadn't thought of it myself. And so he and I started just meeting one-on-one, because I wanted to hear more and talk this through. And then we started bringing other people into these conversations. Monica Williams brought her into the conversation, and then worked together on that call to action paper. And it was something that was such a learning experience for all of us, because we all had been trained in this overcorrection model and had to sort of grapple with that. And I like sharing that story, because what I don't want when I talk about justice-based ERP is for people to think that this is sort of a scolding or a finger wagging of like, how could you possibly do these overcorrection exposures? You should know better. But rather, like, we've all contributed to this, and now that we're thinking more deeply, we can do something better and different. And it really is sort of a journey for all of us. So that's really where this work started, and sort of expanded from there. And I'm really pleased at how well this approach has been disseminated. I sort of laugh when I go to the IOCDF conference. I hear people throwing around this term left and right, as though it has been in existence for decades and not just published 3 years ago. So it's been a really heartening experience.
Thank you so much for sharing that. And I'm so glad that you and others, right, kind of listen to each other, take in each other's experiences so that you can share this with the world. I very much appreciate that. So thank you again for joining us today, Dr. Pinciotti. We hope you all guests enjoyed today's talk and found it relevant to your practice and the work, that we do with the communities we serve. As always, a recording of this talk and all the year's talk will be posted on the Just Talks YouTube page of the Psychiatry Change webpage. And thank you, Dr. Pinciotti, for closing out our 2024-2025 Just Talks lecture series. We really appreciated your presence and thank you so much.
Thank you so much.
Bye, everyone.